All right, good afternoon, everyone. We are just about 1 o'clock on the dot on my side, East Coast time. See, we still have a few folks joining in the room, and that's great because I've got a few intro slides from NACCHO, and then we'll kick off the webinar. But first off, let me just welcome you to today's webinar. My name is Chelsea Gridley Smith. I'm the Director of Environmental Health with NACCHO. That's the National Association of County and City Health Officials. And today we're going to be co-hosting and sharing a webinar called Testing a New Virtual Tool, Planning and Implementing Extreme Heat Interventions. A few housekeeping tips for today. The mute or the chat feature has been disabled for participants. Instead, there's a Q&A box. At the bottom of your Zoom screen, you should see a Q&A box with icons that will tell you how many questions are in there. You can go ahead and enter your question for the speakers in that box. You can also upvote a question that you may already see in the queue. And I'm going to be working with my colleagues here to monitor the Q&A box, and we will get to your questions as we proceed. As a note, the webinar today is being recorded. We will be sharing out this webinar afterwards, and we'll jump right in. Next slide, Jeremy. Thanks. And so if any of you are new to NACCHO at large, just a quick overview. So like I said, this is the National Association of County and City Health Officials. We are the only organization that's dedicated to serving every single local health department across the country. Right now, that's a list of over 3,300 local health departments. Some are dues paying, some are not, and we support every single one of them. We support the over 180,000 staff who work in local health departments. We are a leader in providing cutting edge skill building, professional resources and programs, seek health equity, and support effective local public health practice and systems. You can see on the right-hand column, there is a list of all of the kind of work that we do at NACCHO. It includes advocacy, partnerships, funding, training and education, networking, resources, tools, and technical assistance. Next slide. Local health departments, if you're not familiar as much as you could be, they impact lives every single day. And oftentimes it's unseen, unsung heroes in the day-to-day world that you might exist with and interact with. Local health departments provide services in food safety, immunization, tobacco control, emergency preparedness, injury and violence prevention, chronic diseases, maternal child health, clinical care, chronic, everything, environmental health. As I said, I'm the director of environmental health. And so at NACCHO, I work with a team of folks who cover environmental health projects and activities that include food safety, vector control, and so many other things. And today we're talking a little bit about some of the weather-related and climate-related health issues. Next slide. We'll do a quick overview of some of the work that we do at NACCHO. So within the programmatic field, where you have basically all of the worker bees at NACCHO, we funnel into 4 different buckets of community health, environmental health, which I mentioned is the one that I lead, public health infrastructure and systems, and public health preparedness. You can see little snippets of all the different themes of the work that we do here at NACCHO. And I mentioned today the work we're going to talk about and you're going to hear about really crosses environmental health and preparedness. As if you know, if you're in a local health department, likely the work that you might be doing, if you're working in environmental health or related to extreme heat, your work is going to cross preparedness and response and recovery, as well as environmental health, if not other hats, because we know many of you wear so many hats in the work that you're doing. And I'm really excited to be able to kick it over to Jeremy to do a quick intro of what he's talking about and where he's coming from today and kick us off for our presentation. Thanks so much. Go ahead, Jeremy.
Great. Thanks, Chelsea. It's a pleasure and an honor to be partnered with NACCHO on this. So I'm going to be talking with you today about a new tool that we have developed and are being supported by the National Institutes of Health to test. It's a tool that supports the implementation of evidence-based interventions for extreme heat. We've got a big, strong team working for us. I'm Jeremy Hess. I'm a professor at the University of Washington. I'm trained as an emergency medicine physician and continue to practice in our Level 1 Trauma Center in Seattle and at our university hospital. We're joined in the project by Brad Kramer, who is the director of the climate program at Public Health Seattle King County. Unfortunately, he's not able to join us here today. So I'll be presenting the pieces of the talk that focus on the work we've done with partners in Washington State and in particular in King County, where we piloted the tool 2 years ago. You've already met Chelsea, and then Aaliyah, you want to say a little bit about yourself?
Yeah, great. Thank you, Jeremy. Hi, everyone. My name is Alia Al-Sadi, and I am a program analyst at NACCHO. I work on the environmental health team, and I work between our climate change portfolio and our food safety portfolio. And I am happy to be here today with all of you. So thank you. I'll pass it back over to you now, Jeremy. Thanks.
Great. Thanks, Alia. Okay, so today I'm going to talk to you a little bit about extreme heat events, which I imagine you know something about, or you wouldn't have shown interest in the webinar. But still think it's important to talk a little bit about extreme heat events and how they affect population health and how the hazard is changing. Then we'll move on to discuss some of the interventions that we can use to protect people from extreme heat and the challenges around implementing them, especially at scale. And that flows right into a short portion of the talk that focuses on decision support, what it is and why we need it, and then what we've developed to try and fill what we perceive as the gap there. Uh, then I'll talk a little bit about how we validated the platform and its estimates and used it for community engagement in King County. And then I'll talk to you about the trial that we're doing and leave lots of time for questions and answers. So extreme heat events, as we all know, and many of us have probably already struggled with some of them this summer, are becoming more frequent and severe. Extreme heat's the leading killer of leading weather-related killer in the United States. Uh, we all know that heat is a very dangerous hazard. Of course, cold is a dangerous hazard as well. The risks from heat, as you can see in this figure here, increase pretty steeply over the minimum mortality temperature, which is essentially the average temperature over the year in a given place. And in cities and other places where that hazard is amplified even further, it's even deadlier. Now we know across that whole spectrum that there's risk, but the extremes are particularly dangerous. They really overwhelm many of our defenses and create challenges in some cases with mutual aid and supporting each other during extreme heat events, which, as you can see in this slide, uh, just about a year ago, the entire United States was under really extreme heat conditions, and we're seeing that currently in Europe. We've already experienced one major heat wave affecting many states here in the US, and it's only now the beginning of July. Around the world, we're seeing that extreme heat exposure is becoming more common and frequent. This is the result of human-driven climate change. We're seeing an impact on extreme heat exposure, as you can see on the right here, in all countries of the world. And this increased exposure is leading to significant increases in climate change attributable heat mortality. Unfortunately, we don't have surveillance in many parts of the country where we'd like to see what's going on, but the places where we do have surveillance that's credible, we can see there's a pretty clear increase everywhere we look. This is most pronounced in lower income and more equatorial regions, where it's already hot and additional increases in temperature make conditions even more dangerous. In more northern latitudes, the changes in the hazard are more extreme, but they have a little more room to run before it gets particularly dangerous, except when there's a really extreme event. And as we're seeing, as the climate changes, there are some common changes in the way that hazards are shifting. So what we're seeing frequently is that under a changed climate, we have more intense hazards. So the figure here, the hazards affected by climate change are in red, and you can see historically we would have an extreme event, but now that extreme event is typically much more intense than it was before, and happening more frequently, often lasting longer, and crucially earlier in the season. We're seeing lots of early season extreme heat events. We had one in 2021 in the Pacific Northwest in on late June, and it was devastating, not only because of its intensity, but also because it came much earlier than we normally would see any significant heat in our part of the country. It also came on very, very rapidly. We normally would have about 10 days of warning for an extreme heat event. In this case, we had 5. And we had temperatures that were about 40 degrees Fahrenheit over our historical average. It also covered a very large extent, affected the entire Pacific Northwest. So from Portland, excuse me, from Oregon up through British Columbia and east over into Idaho and Montana. What we can see from this figure here, which is from the Intergovernmental Panel on Climate Change, is that we're seeing the biggest changes on the most extreme events. So depending on the level of warming that we see, we're currently right about 1.5 degrees. Historical events that occurred once every 10 years are now happening about 4 times more frequently. And 50-year events, so things we would have seen maybe once in a generation, maybe twice, are now happening about 9 times more frequently than they were. And the more warming we see, the more these trends are amplified and the more extreme heat events become really frequent and challenging. We know that there's potential for mortality reduction. This image shows the organization of a heat action plan in Ahmedabad, India, which is a plan that I worked with a team to help implement. It took us several years, probably about 10 years overall, to from the start to the finish of the project. But it was a comprehensive and very effective program that included multiple sectors. And when we evaluated at the end of the implementation period, we found that, in fact, it had really had a significant impact on mortality. The relative risk of mortality during extreme heat went down substantially, as you can see here in the figure on the right. So there is potential for concerted intervention to make a substantial difference, but we have some challenges there. Those of you who study implementation science may know the mantra that it takes 17 years for an effective intervention to be implemented in half of the environments in which it should be. So we have some significant challenges. We know there are a lot of things we can do to protect people against extreme heat, but we have a lot of challenges getting that information out, helping people understand which interventions are most effective, but not only that, which interventions are most appropriate for managing the risk in their particular community. And I'm going to talk a little bit more about that in a bit. Risk can be conceptualized as the intersection between the hazard, in this case, heat, exposure, which means for something like heat, basically being in the space where it's hot, not necessarily in a house that's really hot or outdoors where it's really hot, but just in a place where there's an extreme heat event. And then a whole host of different vulnerability factors, which may have to do with physiologic susceptibility, extremes of age, having some mental health challenges that may get in the way of understanding heat warnings or other things, up through poverty and not being able to afford air conditioning, even if you have it. When we look at vulnerability, we actually see there are quite a few different factors that interact, some at the individual level, some at the household level, and all the way up through the community level. And these vary substantially by location. And this can affect what is the most appropriate intervention to choose in a given location. And of course, hazard and vulnerability interact. So this is an overlay of hazard conditions in the United States with extreme heat on average historically, and then social vulnerability to hazards. And I know with this particular overlay, it's a little difficult to see the interaction, but there is quite a bit of interaction between these different vulnerability factors, especially over the course of an entire heat season. So we find ourselves with a challenge. We generally know what's driving risk related to extreme heat. We also generally know what protects population health from extreme heat. And we know that communities have very specific risk profiles. They have specific priorities and they have specific needs. And we don't really have a good synthesis of all of this information to help us make decisions. And it's getting even more challenging because, in fact, when you look at all these different interventions, and in our work, we've identified well over 40 that are distinct and important, they all have different factors that affect their how good they are as a particular fit for a location, and time over which it takes to implement them and over which they will become most effective, different cost profiles in terms of both initial capital outlays and operational costs. And then they affect the communities in different ways. They have different amenity profiles and other things. So the question of what to invest in becomes challenging and often takes a relatively long time, because putting together all that information, gathering input and other things is a time-consuming process. And we're in public health. We want to engage the community and make sure that we're being responsive to the community's needs. But one problem there is that sometimes that can take a while. So we need something that helps us with decision support, that speeds up some of those processes and facilitates community engagement. And we need decision support that helps us understand where the risk is headed. So how do we think about changes in extremes? How do we think about just persistent heat over time? And how do we think potentially even about interactions with other hazards? As I said before, when we look at heat-related health impacts, there are a whole host of different factors. This figure is translated from a systematic review of heat interventions that was done to prepare the city of Vancouver, BC, in Canada for heat action planning and other climate adaptation work. And we adapted it to the US context, adding in particular uninsurance as a significant driver of health impacts. And you can see there's quite a diversity of different factors that in the literature are known to affect population health. We, in preparation for this work, have also tried hard to figure out how to think about effectiveness of interventions in a systematic way that resonates with public health, and settled on the REAIM framework, which many of you are probably familiar with. REAIM is an acronym, and it stands for REACH, which is how effectively an intervention reaches the target population, how effective it is at actually protecting people's health, how widely is it adopted once it's put out there, and then is it implemented with fidelity? So is it implemented in the way that it was designed once you're out of a controlled setting? And then maintenance. So when you look at an intervention over time, is it maintained? Does the community feel like it's effective and valuable and continue to invest in it? Our decision support framework is based on the recognition that a lot of this planning is very local, and that the risk is also very local. And so we wanted to put together a platform that estimated risk at a local level in a very transparent way, that people could understand what was driving the risk and communicate that to their partners so they could collectively make decisions together. We also wanted to be very clear about risk reduction opportunities. What not only is the effectiveness, we tend to focus a lot on that in public health, but also, what is the cost? How long does it take to implement these things? Is tree planting better than subsidies for utility bills in terms of protecting vulnerable populations and historically marginalized communities? And then putting it together in ways that really support the discussions that need to happen to facilitate adaptation at scale, because things are changing rapidly, as I mentioned. So I'm going to tell you a little bit about our platform, which is called CHART. And chart focuses again on these different areas. So we focus on the hazard. In this case, we're looking at historical extreme temperatures and thresholds for adverse health impacts at a particular location. So we use very granular historical weather data to import information on the hazard into the platform. We include information about population exposure. So all our risks are population weighted, though we have strategies for dealing with more rural areas and focusing more on vulnerability, which is the main driver in those locations. And the vulnerability information we include has all those different factors that was in that were in that diagram I showed you a few slides back. So social factors, economic factors, population health factors, and environmental issues in a given place. And it shows how all those things interact. So I'm providing some screenshots of the tool here. We're still putting the final touches on all of the different modules, so I can't walk you through it live until it's all fully assembled, but these are screenshots from the tool, and this shows King County in Washington State, and it shows the heat health risk in the county. And this area here is southern King County, so Seattle up here, and then South Seattle down here. And as you can see, the risk is substantially higher in that area, which is largely driven by several factors related to impervious surface and tree cover. The tool lets you pick a county or a city to gather information about heat risk. And then it just shows you what's going on at the census tract level. So for many highly populated areas, census tract is about 3 to 5,000 people. So for a city, it's roughly the size of a large neighborhood. So you get quite granular information about what's going on in a given location. And you can see, I'm going to switch back here, this darker red area that you can see on this slide corresponds to the city of Auburn in King County. And this is Auburn's profile, where I'm sorry, this is Auburn's profile down here. So you can see that in South King County, in the city of Seattle, there's substantially increased risk, again, related to the relatively high impervious surface and low tree cover in the context of an older population, a less wealthy population that has a lot of underlying health conditions. The tool gives you a breakdown of contributing factors of risk by population, by area, and it focuses here on the hazard, the exposure, and then the vulnerability. It also breaks it down by population and then gives you a sense of comparison. So it'll compare your county to the larger area of your state and give you a sense of where you stand relative to other areas. It will also break down the risk according to about 35 different risk factors. So when you click on a county or a census tract, you can then drill down into all the different issues that are affecting the risk in that location, including and give you historical information on temperature, and give you all the raw data that we use to model the estimated risk, and show you how all of that compares to a comparison population of interest. It will also tell you about interventions. So as I said, we have about right now 48 distinct interventions in our pool, and they're broken up into different families. So we have 3 main types of occupational protections. We have 3 different interventions under indoor cooling, et cetera, as you can see here. Broad array of interventions, some of which are behavioral, some of which are focused on the built environment, some of which are focused on health systems and emergency medical systems and disaster preparedness, some of which are focused on non-governmental organizations, connectivity, transportation, mobility, and then other policies, et cetera. And in each case, we have done systematic literature reviews and condensed all of this information into reports. And these reports are, depends on the intervention, but roughly they're several pages long. And they collect and systematically present to users information about all of these factors that go into whether the intervention is recommended for your particular community. So it pulls in information about heat risk for that location. Again, a city or county level is the base. And then also information about goodness of fit. So for tree planting, for instance, generally the literature supports that having about 30% tree cover is where you tend to start to see an asymptotic relationship with protection. Anything under that, you want more, but anything over that, and it's great, but you may not necessarily see a substantial health benefit. So we've developed a model to estimate whether you need to plant more trees in your particular location based on the observed tree cover in that place, and then some other factors related to the kinds of trees that can be grown there and water availability and other things. Then you'll see there's a cluster of bubbles here around reach and effectiveness. This is the re-aim model. So we have subsections of the model that look at historically what we've been able to identify about these interventions and their penetration into the practice environment and if they're maintained, et cetera. Then we look at factors like administrative ease. Can a health department take this on easily? Is this something that one person could manage as the officer for a heat action plan, for instance, which was the structure we had for the heat action plan in Ahmedabad? Or is this something like green roofs that is actually, in reality, quite difficult to administer because it involves coordinating a whole host of property owners all across a city, very challenging to administer centrally, and therefore maybe not the best thing to take on with a limited budget. Then we talk about amenity value. So will a splash park in a particular neighborhood be a place where people can gather? Will it build social capital? Will it enhance the uh, aesthetic experience of being in a particular place? Might it alter the experience in a way that some people are disinclined to support? Might it have unintended consequences like gentrification or other things that could harm the population if you weren't very careful about how it was implemented? And even if you are careful, are there unintended adverse impacts that you need to be aware of and to monitor? And then lastly, we pull in information about capital and operating costs over a 5-year time horizon. Some of these interventions don't cost much at all uh, to set up in terms of capital, but they may be relatively intensive in terms of operating costs on a human level. Some of them, like distributing air conditioning to a community that doesn't have high penetration of air conditioning, might have relatively higher capital costs, but not cost much to operate beyond that. So we synthesize all of that information into into a recommendation model for each intervention, and then present that for each location and provide the user with information about how to, what the model would recommend as a starting point for conversations internally in the health department and with partners in other sectors and with the community. You can see here, this is a screenshot of the model for tree planting for King County. And as I highlighted, that region where there's particularly high risk in the Seattle area and South Seattle, there's also a high recommendation for planting trees because there's so much impervious surface there. And that would be an intervention that would, over time, make a substantial difference. It's not the only intervention we would recommend in this location, but it's one of several priority interventions we would encourage a community to consider. And for each intervention, we highlight alignment to risk, effectiveness, et cetera, and all these different factors, and then synthesize all of that to give you information about what you might consider in your community. And following are some screenshots for other places. We've set the model up so it's all relative to relatively local regional climate and local environment. So you get a sense of how your county or city stacks up against other places within the area in which decision makers are going to be making decisions for your particular place. Generally, that is not at the national level, so we don't focus at a national level, we focus at a city, county level. You can see here also for California and Riverside County, and then some city models here for Los Angeles and Dallas and New York. We recognize that some of these health departments have probably developed some of their own regional models that they may prefer to use. But we figured it was best for us to create a model that has national coverage so that any organization that didn't have access to those resources would be in a good place to start these conversations. Now, this is all good and well. I recognize lots of pretty maps and other things, but if I were you, I would be asking, okay, but how well does this actually perform? And we have, of course, we're reaching out to you because we want to find that out, but also we have done some preliminary work to explore what works well, what doesn't, and validate as much as we can. This is a novel tool. We've been ambitious in the design and kind of leapfrogged a number of other things. And so we have a number of ways in which we need to validate this tool. We have piloted it with multiple stakeholders in Washington, in Washington, and gathered a lot of feedback around the initial version, which we then have incorporated into the new model that we're using. And we've tested the validity of the risk estimates, and we're exploring the utility of the overall platform, hopefully in partnership with you. So I'm going to tell you a little bit about our experience from King County and the feedback we've gotten there, and then also some of the validation we've done, and then we'll talk a little bit more about next steps. So, excuse me, the
Jeremy, just a quick moment to interject that we did have Brad able to join us. So if you
oh,
do at all want to pitch it to talk about their experiences or introduce that section, yeah, that was a lovely, lovely surprise for us. And I wasn't sure if you had seen that he was able to join. So
I
I will
didn't.
let you take it. Okay.
That's great. Well, Brad, tell me, how would you like to do this? Would you like
Yeah,
to go through these, or would you like to be here and answer questions? Either way is fun for me.
I can chime in at your face validation slide if you can just prepare I can share a little bit of my experience, and then I'm definitely here to answer questions, particularly from my peers from other local health jurisdictions.
Great. Thank you. I'm glad you're able to join. So King County is where we practice in Washington State. It's about 2.3 million people. It's a diverse county, roughly 50% white residents, and then the rest of the population is outlined there. It's a pretty prosperous place overall, also an expensive one. The median household income there is about $120,000. These are numbers from a couple of years ago, so I'm sure they're all higher now. Per capita income there is $71,000, but we also have a substantial poverty rate of close to 10%. And it's quite a varied place in terms of there's some very urban areas and then a lot of suburban area and quite a bit of rural areas with quite varied terrain that goes from sea level all the way up into the Cascade Mountains. It's a temperate area where the northernmost large city, or Seattle is the northernmost large city in the country. But of course, like most other places, uh, in the northern areas in particular, it's warming very quickly. And in 2021, as I mentioned, we had this extreme heat event, which we called the heat dome. You can see some images, or an image on the top there, of the temperatures, record-breaking temperature across the region, particularly on June 28th, 2021. And we saw a very clear impact on population health during that event. Our county EMS agency logged the largest number of calls it had ever received in one day on the hottest day of the heat dome. And we saw a substantial increase, in particular in calls related to heat. And so this is a bit of a natural experiment, which allows us to see whether our heat risks are well calibrated for the health outcomes that we observed. So this is a map of heat-related illness, ED, emergency department, or EMS visits by population during the extreme heat event. So not just that one day, but the whole event. This is prepared by the climate epidemiologist at the Washington State Department of Health, Randy Stalter. And you can see there's quite a diversity in terms of the impact overall around King County. And what we found was a moderate correlation between our heat estimates, where heat risk is high, and the number of calls and ED visits for heat-related illness in the county. But importantly, we checked it against all other available metrics of heat vulnerability, and it outperformed them all. So moderate correlation, but better performance than any other available metric. And then, Brad, if you want to talk a little bit about the validation we did in Auburn, that'd be great.
Hi all, Brad Kramer here. I manage a climate and health equity initiative at the Seattle King County Public Health Department. It's been a great privilege and joy to work with the University of Washington across many projects related to climate, but in particular around our extreme heat work, which has gotten a lot of attention following that heat dome in 2021. But we didn't have the tools to necessarily combine all of for a full vulnerability assessment, and so this tool has been a great asset to us. And so we were in working collaboration with the University of Washington team and Jeremy Hess here. We were able to also supply additional data and work with them on looking across our different data availability. We were also able to bring it in front of a group that we had been working on. We brought together 15 folks from around Auburn, Washington, that had both lived and professional experience with the heat dome and with extreme heat. And we brought them together for nearly a year in a series of workshops focused on developing community determined solutions for heat. We did several different modeling and sort of systems thinking activities that helped to bring to light all of the health harms for sure around heat, but then also everyone was very anxious to put together solutions in order different interventions and different policies that could counteract all the heat harms. In that process, we were able to bring forward the maps and show precisely where things live within Auburn and what the vulnerability assessment is showing us and how that can inform the policies and practices. So really bringing to life this decision support tool in a very dynamic way. And I do a lot of different participatory processes. I wasn't sure how this would go to bring sort of full table size maps in front of them and see how they would interact. But it became very intuitive. People were able to, once they were able to place some landmarks, they were able to very much explain how these, why the shades were of vulnerability were different, and what that might mean in terms of placing the different interventions. What that means for us, though, it certainly informed the practices of the city of Auburn and brought to life what we were doing as that community participatory group. But Auburn has a lot of its area defined as a urban heat island where it retains heat, especially in the evening, and continues their exposure and risk. It's not unlike some of our other suburban cities. We have 39 cities in King County. And so as we roll out the results from Auburn, we're now able to begin to engage other jurisdictions. And with this tool, we're able to bring them resources in order to have those broader conversations. And in addition, as our cities are beginning to even fold in climate into their considerations for their comprehensive planning. So this can help us with our conversations moving forward with other jurisdictions. I think that's all I wanted to add, Jeremy, but I'm here for questions and answers that sort of give that perspective.
Great. Thank you, Brad. And I'll add that Public Health Seattle King County is a very well-resourced and capable health department that has been doing a lot of work on extreme heat and other climate sensitive hazards on its own. And I think it's reasonable to say that engagement with chart supplemented that, and there was positive interaction between those things. It certainly didn't supplant it. And people were able to pick and choose from the different tools that were available to them and the resources they had internally, and use this tool to support conversations while also helping us refine the tool going forward. So it was a nice symbiotic relationship that didn't supplant ongoing activities, and I think where they had insights that they felt were they were more confident in, or they'd already arrived at, that were separate from chart, they were still able to fully lean into those and develop programming in that space that didn't feel too dictated by using this tool. So now I want to tell you briefly about the trial that we're participating in. We, in partnership with NACCHO and Public Health Seattle King County, are recruiting local health departments to participate in a randomized controlled trial of CHART. All the participants in this trial are paid. It's funded by the NIH. The overall approach is that we're recruiting actively, and then when we have a sufficient number, we're going to hopefully stratify by region if we have enough people or sites express interest, and then we will randomly select. Excuse me. First, we'll do a baseline survey, and then we'll randomly select, do a baseline survey, and then randomly assign to intervention or control. And the intervention will receive a facilitated engagement with chart. The control will receive information that is the information that chart in many ways is built on, but not the same engagement and not the tool. They'll have a 1 year to engage with their process, and then we'll do a follow-up survey. And then with the intervention group, we have a series of key informant interviews afterward to explore things further. The specific aims of the trial are here, essentially testing the intervention, which is a facilitated engagement with the chart tool, and looking at the effectiveness of the tool using the REAIM framework, and also its effectiveness as a delivery mechanism for informing implementation of all these other interventions we know to be effective. And then we also want to get more insight into chart and what worked well and what didn't for a given institution. And so I'm going to do some qualitative research to explore users' perspectives, how it aligned with their ongoing work, and examine, and we're going to analyze that using the consolidated framework for implementation research. The overall timeline is outlined here. So we've been doing some recruitment this spring. We hope we will soon have enough interest that we can start to screen applicants and stratify and go through the enrollment process. For all sites that are enrolled, they'll get $1,000 to start. Then they'll do the pre-intervention survey, which I would say probably will take 1 to 2 hours of time, not a lot, and then get a second payment when that data is in, and then they'll be randomized and get the intervention or the control. And then late in next summer, they will fill out the post-intervention survey. And then, as I said, the intervention group will have some additional interviews. The intervention group will receive this facilitated engagement, which is essentially a series of virtual meetings with an introduction to the platform, overview, kind of a guided tour. Then they'll do some independent exploration, come back to us with questions and answers, questions which we'll answer. And then in some cases, we have found that health departments like to bring data that they have that isn't publicly available and incorporate it into the model. So in the case of King County, this has been mostly health data that's at a finer resolution that's available publicly. And so we are able to refine the model to incorporate a bunch of information about chronic health conditions that are known to affect heat health risk. We incorporate that into the model and then use that model to support their decisions. And then we will have a meeting about what the process is that they might use to plan interventions and think about implementation, and highlight any utility that the tool has for that process. The control group will get a packet, and will be a comprehensive packet around heat and health risk and interventions that are known to reduce risk, implementation of those interventions, how to think about planning and evaluation and other things. I very much hope that you'll express some interest in participating. I know it's not a huge cohort of sites. I also know that things are quite tumultuous at the NIH right now, and that it is certainly possible that we will lose the funding for this work at any point. And if and when that happens, we will no longer be bound to the same approach to exploring the utility of the tool. So we would very much appreciate your interest. I think there are a lot of good reasons for expressing interest. It's first and foremost, regardless of which you might get randomized to if you participate. I think there's a lot of learning here. There are a lot of resources available to participants that will support heat action planning for their jurisdictions. It's a learning opportunity for our specialty. We don't do randomized controls that often. We're trying to push the boundaries of what we can do in terms of building evidence for these things. And we've worked hard to connect our approach with existing frameworks and theory around effectiveness and interventions and implementation. So we've set up what I think is a good learning opportunity for our whole discipline. It's an opportunity to support NACCHO. And NACCHO is really supportive of our work generally. It's supportive of your work, and our work moves forward through research and collective learning. And I'm very excited about NACCHO's commitment and engagement with us, their readiness to work with us on this. They've been great partners so far, and it's an opportunity separate and apart from all this to support NACCHO. And then it's an opportunity to advance heat action planning. And as we've seen, the risk is increasing pretty steadily, and we're keeping up in some places and not in many others. And you can see this in the data in terms of the number of heat-related illnesses and EMS calls and other things. It's going up substantially. For a long time, the US mortality related to heat was actually going down, even though the hazard was becoming more frequent and severe. And that's no longer the case. So we need to advance our heat action planning more broadly. It's also, I think, an opportunity to explore a platform that allows for standardized engagements, standardized assessment, excuse me, community engagement, which of course is at the core of what we do in public health, and then intervention planning at scale for your jurisdictions. So I hope that you will consider expressing interest. An expression of interest is only that. It means that you say, yes, we would like to learn more, consider being involved. We understand you would need to talk with people in your health department to clear this. And there, of course, are some eligibility questions and other things to consider. If you have any questions for any of us, all of our emails are here, and we look forward to answering any questions that you have. Thank you.
Thanks so much, Jeremy and Brad, for the presentation. And you might want to leave that last slide up with the QR code while we go through questions, because we're getting some in the chat, and that they can just sort of click into that and access the link to the form.
Yes.
Yeah, thank you so much. We do have quite a few questions coming in through the Q&A box. And I opened up the chat. So if you do have questions and you're having trouble with the Q&A, feel free to put them in the chat box. Those go directly to us hosts and the panelists. And I will kick it over to Alia, who's been monitoring, to kind of relay these questions to you, Jeremy and Brad. And Oma, thanks.
Great, thanks, Chelsea. Okay, so the first question from Terry is, do you support identifying a heat index such as 105 degrees Fahrenheit as a threshold for recommending the cancellation of outdoor events, as NYC does?
So I'm not sure, Terry, if you mean, do we support it from the point of view of, do we endorse it? Or do you mean, does the tool have a functionality that uh, speaks to that question? And I don't know if you want to clarify, or I can just address both. Are participants muted? Okay,
They are. I
so that's fine.
Hi,
did
hi, this is
offer up.
Terry.
Go
Can
ahead.
you hear me?
Oh yeah,
We
hi
can hear
Terry.
you.
Oh, yeah, thanks. I'm in Tucson, Arizona, and we're working on our heat plan. And my particular role is community engagement coordinator. We have very active outreach teams that go out into the community. For instance, Juneteenth, and
Mhm.
it's quite hot. And so we have multiple things we're thinking about. There's recommendations for people who are hosting outdoor events. And then there's our own policies for the safety of our own staff.
Mhm.
And so we're working on guidance for people creating events. And we're interested in that New York City model where
Mhm.
it has a lot of information with strategies at different temperatures. Um, and then thinking about whether to create a sort of employee policy, like maybe we would in advance say, yeah, we'll be there at Juneteenth from 11 in the morning till 10 at night until we learn that we're having an extreme heat advisory, at which point our outreach staff would have permission to cancel. That kind of thing. We're kind of struggling with it, and whether setting a threshold that is set upon a number makes sense given all the variables of acclimation and different people's tolerance. And so I just was wondering what kind of thoughts you have about that.
Yeah. So well, thank you for clarifying that. That's very helpful. And I know this is a question that jurisdictions are working through related to a number of different climate sensitive hazards. Certainly in Washington, we've wrestled with this around heat, and we've also wrestled with this around wildfire smoke. But other places have other challenges too. So the chart tool does not specifically have a module related to event cancellation. What it does have is a lot of information about occupational exposures, thresholds at which you might consider modifying practices in a stepwise fashion. That provides information about all those stepwise practices, provides information about ways that personal protective equipment may make it safer for workers to work in hot conditions for longer. Um, and again, presented according to that same standardized template in terms of thinking about effectiveness and cost and all those other things. Generally, these are decisions that are made at, in Washington's case, there was a state law that then gets implemented across different jurisdictions. Other places, it's probably more localized than that. So chart, we don't have an easy way to pull in up-to-date information about all those things nationwide yet. So we don't have a module that specifically speaks to event cancellation. And it's a good suggestion for thinking through for policies. We do have information in chart about heat action plans, like municipal heat action plans, and many of those include policies like what you have outlined. And so there's discussion of all of that in that area of guidance as well.
Thank you.
Absolutely.
Great, thanks. Our next question comes from Ariel, and Ariel is asking, is the outcome of the intervention model air temperature or health benefits, e.g. reduced heat deaths?
Neither. So the model estimates risk. So it's the confluence of population weighted risk, or the combination of hazard and vulnerability if you don't include population. So it basically tells you in a given location the combination of all these known drivers of heat related health risks and then hazard thresholds historically in the recent climate where those intersect and how they construct risk at a population level. And then, so that's the hazard model and the vulnerability assessment model. And then there's the model for interventions, which recommend specific interventions that cross a threshold of utility for a given location. So there are a whole bunch of models in chart, but those are the two sort of model outputs, really. It's not, we're not specifically saying this will save you this many lives. We're saying this is worth pursuing as an intervention based on its evidence profile and its costs and many benefits and other things, given the heat risk in this location.
Great, thank you. I know we have 5 minutes left. Would you like to answer one more question before we wrap up?
Sure,
Okay.
I'll go quickly if I can.
Great. Okay. So from Anonymous, how are factors such as operating costs and capital adjusted based on location? What economic data is being considered here?
So these costs and capital are not adjusted by location. So we don't adjust operational or building costs, by location. In Seattle it would be more expensive, but everything is more expensive in that location. So we pull information from what's available in the peer-reviewed literature and the gray literature, and then through web searches on the cost of the particular intervention. In some cases, we're going, looking at actual providers. Some cases we're going to expense reports. We get information from a wide variety of sources. And in some cases, this information is actually difficult to come by. Which I think is part of the reason it's not systematically considered in implementation. But we've done our best to assemble information across a really wide variety of interventions. And so there's some wide confidence bars in a few of the estimates, but in general, we at least are able to provide some sense of relative cost, both from a capital and an operational standpoint, so you can start to think about the portfolio of interventions that you'll endorse.
Great. Would you like to answer one more?
Sure, I'll just go down them quickly if I can. So we have a small city, Cambridge. Could we partner with you as a region in Boston and Somerville to cover more area? So I presume that Boston and Somerville are separate health departments in this case. For the study, we would, we're organized, so the unit of analysis is a health department. So we would need one health department to be the primary. If that health department, as part of its approach, we're being quite flexible in the approach that health departments are using. So if they wanted to partner with other local health departments in the region and share information, then that would be a reasonable thing. But we would be focusing on one health department as the site. Is the chart platform available free of charge to local health departments? It right now will only be available through this trial. Our goal certainly is to make this freely available. We need to test its applicability and utility first, and we're looking for ways to support that free availability of the platform. And then let's see. Can you give a few examples of what other vulnerability tools and metrics you compared yours with? We compared it with different heat-related vulnerability indices produced nationally by CDC and NOAA, and also to local vulnerability indices developed in California. Beyond ambient temperature, what factors do you consider most crucial or critical in determining the severity and health impact of an extreme heat event? Oh, this gets into a lot of interesting questions. It depends on the location, actually, which is part of the reason we set up the models the way we did. But there are a lot of underlying population vulnerability factors, people who are unhoused and who struggle with different mental health challenges. In the heat dome in the Pacific Northwest, schizophrenia emerged as a really substantial driver of mortality risk, for instance. So living in urban heat island, being marginalized in any number of different ways makes it likely that people don't get the messages or aren't able to act on messaging in the same way as people who are more empowered. So a lot of those different vulnerability factors combining with built environment factors and intensity of urban heat island and then access to cooling, whether it's at the household level or more locally in their communities, those seem to be the biggest drivers. Would the health district be able to work with you to get heat maps from the past 10, 5 years, last year, so there could be some comparisons as to why interventions are needed? Interesting question. The current structure of the model focuses on extreme heat pulled from the last 30 years, so it doesn't provide a trend analysis. That certainly would be possible to do with the data we have available. So I think if that was something that a particular jurisdiction wanted as part of the intervention, we could generate that easily.
Jeremy, I'm going to have to interrupt. We are at
Okay.
the top of the hour. And we did get some few questions from folks who asked if we could summarize the questions that we received
Sure.
from the chat box and then send out afterwards. So I think we'll work with you and your team to make sure we kind of have these answered offline and we can send it to the folks. Because they're really good questions, and I love how thought-provoking they really are and trying to think about ways and using this tool to help them. Which
Great.
is really, really exciting. So we will do that, folks. For those of you who stayed on just a couple seconds over here, we will be summarizing the FAQ or the questions that we received in the chat box and the Q&A box, getting answers from the team at the University of Washington, and making sure we share all of that back out with you all. Timeline will probably be early next week, just given the holiday that we've got this week. Just a final thank you to everyone who attended. I think we had over 400 folks joining live. We had almost 600 registrants before the event, so everyone will receive all of this information. As you heard from our speakers today, be sure to follow up with them, share your interest, indicate that you're interested in this. You're not signing a contract right now. You're really just indicating that you're interested in learning more. We know this is going to take a little bit of time to get things set up, but we are very excited that so many of you turned out today, stayed for the webinar presentation, answered so many or asked so many great questions. And we're looking forward to an exciting project with you, Jeremy, and your team.
Likewise. Thank you. And thanks to
Thank-
everybody who
Yeah.
came to hear about it.
Yeah, and thank you so much, Jeremy, Oma, and Bradley for joining us today and sharing your experiences, and Alia for helping us monitor the chat.
Yes,
All right,
thank
take
you.
care, everybody. I hope you have a safe, happy 4th of July weekend, and we'll be in touch next week.